welcome everyone tonight to this edition of the Baltimore County Fire Department Emergency Medical Services Training Series. We are honored tonight to have our speaker, Dr. Dave Berman from Johns Hopkins Hospital, Department of Anesthesia. Dr. Berman started his career, much like a lot of us, as an EMT and then became a paramedic up in New York City. He went to medical school at Mount Sinai and Johns Hopkins. He is an anesthesiologist. He specializes in, I believe, OB anesthesia, among things. And he's also gotten numerous teaching awards. And I'm very happy that he's here tonight talking about a subject that I agree with, things that I wish I'd have known. Without further ado, I'll welcome Dr. Berman. Welcome.
Thank you very much, Jeff. It is great to be here. In my heart, I'm a recovering paramedic. It is a 12-step process for a lot of us. I encourage you, if you're on Zoom, to go to the website that I just put in the chat, or you can take out your phone for a second screen experience and scan the QR code that's on the very top. Please go ahead and do so that we can have some interactivity. It would be great to not just have me be talking to a bunch of black squares. This QR code will be repeated throughout the talk. All right, so before I start, I do want to give a quick shout out as a in memoriam to Sean Barinholtz. He was a colleague of mine at Hopkins, and like many of you, I respected him a ton. He was a huge mentor to me and a mensch beyond measure. You knew Sean in a lot of capacities through the fire department. I knew Sean mostly at work and as a dear friend. I miss him tremendously, and it is largely because of him that I got interested in giving this talk. So I'm really glad to be doing it. I want everybody to take out your phones, and you are going to go to this site. You don't have to put your name in, so please don't put your name in. This is a proof of concept to make sure that everybody knows how this works. All right, a couple of brave people. So far, nobody in the orange or red category. All right, let's see. The hour is young. All right. Okay, and I'm going to put the link in the chat again. For the rest of the talk, I want you to keep that window open, and the questions will continue to update. All right, so far we've got a critical mass of 12 people who've responded. As they say in Jewish terms, it's more than a minion, so that's great. Let's keep going. All right, so what I'm going to talk about tonight, I'm going to talk about really the evolution of EMS practice over time. I'm going to be a little controversial here and challenge some of the dogmas of pre-hospital medicine that I was taught back when I had hair. And maybe we'll talk about the future of pre-hospital care and where I think we might be going. All right, everybody, keep those phones out. Who is everybody here? All right. Nobody's here for the free food. It's good because there's no free food. All right, a whole bunch of firefighters and EMTBs, a couple brave medics, and one probie. All right. All right. And how long have you been involved in EMS? How many years? All right, so a real wide smattering. And a good group of people who've been doing this for 20 plus years. That's great. And I see someone in the Zoom chat said 30. And thank you, no one, for choosing what is EMS. I appreciate that. So we'll talk about a few main things tonight. I want to talk about airway management, vascular access, resuscitation, and hemodynamic management. Some of these may be more ALS than BLS, but we'll talk about all of them, and we'll see where some controversies are, and we'll see maybe where the literature has ended up. And if you've been doing this for a while, this is a word cloud, so respond with text. What is the biggest thing that's changed about EMS since you started? And if you just joined, there's a QR code up top over here. Strokes, okay? And you can vote up or down each other's answers if you'd like. Pain management. Okay. Backboarding, neck and back treatment. All right. So not everybody needs a longboard. Very few people need a longboard. The Burns rule. I would assume that doesn't mean the Burns rule. Okay. Now, when I asked one of my paramedic friends what's changed the most about EMS in his long career, he said the probies keep getting younger, which is an answer I just loved. Okay, mental health. Yeah. Equipment. Yeah, couldn't agree more. And we'll talk a little bit about that today also. All right. All right, so it seems like there's a whole big smattering of stuff. And falls and geriatrics is in the chat as well. I couldn't agree more. Both among EMS providers and among our patients. Sorry, I had to. If you want some references, if you're the kind of person who's a really big nerd, you can take your phone out and scan this QR code for a whole lot of references, a whole lot of the literature, the papers, the scientific evidence for the stuff that I'm going to be talking about tonight. I'll leave this up for just a second. All right, so a little bit about me and my background. Dr. Sago mentioned a little bit. I became an EMTB in 2003 in New Jersey and then in New York. And in 2008, I trained as a paramedic at St. Vincent's Hospital. And I'm not going to say it's related that the year after I trained, the hospital shut down, but I'm also not going to say it's not related. I was at med school at Mount Sinai. I did my anesthesia residency in Mount Sinai also. And then I came to Hopkins for fellowship. I was voluntold that I should be an ICU doc at the beginning of COVID. I did that for a year and a half. And now, thankfully, I'm out of the ICU and just working as an adult anesthesiologist. And looking back, I think to myself a lot that a lot of the skills that I perform every day, I do vascular access, airway management, hemodynamics, pain control, are all the skills that I learned in EMS, just applied in a different way. They're practiced differently, but they're not new skills to me. And when Jeff asked me to give this talk, I thought to myself, what are some of the things that I was taught that were dogma? And of those things, what has stood the test of time and what has been thrown by the wayside? And what are we currently doing that we probably shouldn't be doing? And big picture, when you're practicing medicine, you always want to think that you have strong opinions. I believe this strongly. But your opinions should also be loosely held. My practice in the last 10 years since I finished training has changed drastically. A lot of the stuff that I thought I would never do, I'm doing more of. And a lot of the stuff that I thought I would do a lot of, I don't do anymore because it's not helpful. And it's important to remember that we make decisions based on imperfect information. I've done plenty of needle decompressions for no tension pneumothorax. Right? It's important to know what we don't know, and sometimes we're wrong. So dogma number one, I was always told GCS less than 8, intubate, right? GCS less than 9, tube is fine. GCS 7 or below, tube goes where it's got to go. But remember that intubation is not a benign thing, right? It's not an atraumatic procedure. And if it's not done well, it's really bad. And the challenge is also that especially if your hands are limited and your attention is limited, if you're putting the tube in, that means that by and large, you're going to have to squeeze that ambu bag every couple of seconds, or if you're new, every second, but every couple of seconds for the rest of transport. Right? And there's lots of literature that intubation is not necessary for GCS less than 8. How many times do we take intoxicated patients who are dead to the world, who have a GCS of 6, and we just lay them on their side and transport them? And there are entire units in the hospital. Right? The neurocritical care unit has patients with GCSs of less than 8, and they're not intubated in the hospital. So that original rule was only applied to trauma. That GCS less than 8, the original literature was only for trauma. And the thought was that if you're GCS less than 8, you have an obtunded gag reflex. And if you have an obtunded gag reflex, it means you'll aspirate. And if you aspirate, that means you'll die. But the challenge is that there are a lot of things that may kill you quicker than an aspiration pneumonia, like a failed airway. Important to think about. And the challenge is not just that the GCS less than 8 intubate paradigm is wrong, but also that GCS itself is not reliable. right? There's really good data. This was an editorial from 2011 in the American College of Emergency Physicians that talked about how GCS scores, if you took two independent physicians, emergency medicine physicians, and you asked them to GCS score the same patient, they were showed a video, and they were 2 or more points apart in a third of them. And they were the same in only a third of them. So the discrimination on the scale is really poor. And this was an interesting paper. This is 73 patients in the ED who were admitted for intoxication. The GCS was ranged from 3 to 14, but they had 12 patients with a GCS of 8 or less. And interestingly, they only had one patient who required intubation. But that patient actually had a GCS of 12 and was aspirating. Interestingly, they had 0 patients who had a GCS of less than 8 aspirating. Just an interesting thing to think about. The dogma of GCS less than 8 intubate is probably not a thing. So the question in my head is, do I intubate in the field or not? Right? When I was training as a medic, the answer was always yes. If you ask the question, the tube should be in the trachea. But as I tell my kids, when you know better, you do better. I love the idea of keeping people breathing spontaneously. I love the idea of avoiding positive pressure ventilation, especially if you're masking someone, you're going to insufflate the stomach. And just remember that getting to the trauma bay or the ED is your best friend, right? And sometimes the answer is leave good enough alone. The answer used to be always put the tube in. And now the answer, I think, is leave good enough alone, at least for the most part. And we'll talk about the data in cardiac arrests in a bit. But before we do that, when I was training as a medic, portable video laryngoscopes did not exist. They were not a thing. The McGrath video laryngoscope that I carry around with me every day was not a thing. It wasn't even a twinkle in anyone's eye. Since then, there's obviously been an explosion of airway management products, and I love the toys. But the data are becoming even more clear that for the occasional intubator, someone who doesn't intubate more than a couple of times a year, video laryngoscopy is superior. Right? And it results in a faster first pass successful intubation. But wait, I'm a bit of a dinosaur sometimes. I still make my residents put in arterial lines and IVs without ultrasound. If I have to rely on new technology, does that mean that I'm shittier as an EMS provider? Am I worse because I need to rely on technology? No, absolutely not, right? You drive a car with airbags, you presumably sometimes use your GPS in your phone, you use a defibrillator, that's a new technology. Using these tools doesn't make you any worse of a practitioner. It means that you're following evidence, right? You're helping yourself. And going along with intubation, what about waveform end tidal CO2, which I know is used in your agency? When I was a paramedic in 2008, waveform end tidal CO2 became a REMAX standard for all New York City EMS agencies. And we were pissed. We were so annoyed because previously it was the easy cap things. You broke open the foil thing, and if you saw the thing change from yellow to purple, you knew that you were in the trachea. And we all hated waveform capnography. You had to set up the Zoll, you had to wait for the thing to warm up, you had to put the sensor in. Sometimes the sensor didn't work, sometimes you had to unplug and replug, you had to blow on the thing a little bit to make sure that it detected your CO2. It was such a pain. But honestly, waveform capnography is my favorite monitor in the OR. If I could choose to have only one monitor, it would be end tidal CO2. Why waveform capnography? The tube is in the trachea. I also know that the heart is beating. If I have end tidal CO2, the patient is alive. You also avoid hyperventilation. So often in critical scenarios, we don't realize that we're severely hyperventilating our patients, which is worse. And also, during ACLS, if you get ROSC, your end tidal CO2 is going to blip up. It's a really helpful marker of resuscitation. And also, especially in a trauma or a critical scenario, esophageal intubation is a real thing, but so is inadvertent extubation. The whole log rolling a trauma patient, the whole complex extrication, or self-extubations, right? In patients who are disinhibited. It can be really, really important to make sure that your tube stays in the trachea. And that's really, really critical. So is waveform end tidal CO2 worth it? The answer is absolutely yes. I was not a believer in 2008, 2009. I thought it was annoying. I thought it was terrible. But now nothing else matters if you're not ventilating. So I just spent a while talking about intubation and video laryngoscopy and end tidal CO2. So what you might be wondering is, what about those supraglottic airways? When I was training, it was all about the King airway. You guys may have heard of the King airway. The comba tube was great, really big oral balloon. But nobody wanted to use them when we could just intubate. And I was always told that an endotracheal tube is the only protected airway and that you needed to have a protected airway in a critical scenario. That's what I was told. Dogma. But as it turns out, LMAs have revolutionized ambulatory anesthesia, not just for scheduled cases, but also to rescue failed intubation attempts. We in the anesthesia world have a difficult airway algorithm. And pretty high up in the difficult airway algorithm is put in a supraglottic airway. And our second generation devices have a gastric suction port. So when I put in an LMA, I will often put in an orogastric tube through the LMA to drain the stomach. And the question is, are they enough? Is a supraglottic airway a good enough airway? And this was a study that came out in 2013, so a long time ago at this point. And it showed that among patients with out-of-hospital cardiac arrest who were adults, advanced airway management, that's a supraglottic airway or a tube, was associated with decreased odds of neurological survival compared with just masking. Right? So not only are we not helping people, but we might actually be hurting people, which is fascinating. And I think part of this is probably because we have people hold compressions when we're intubating, rather than doing it either during compressions or during pulse checks. But it's just an important thing for us to think about, right? Not only are we not helping people, but we might actually be hurting people. And putting it into context, right? An LMA is not a definitive airway. But I think it's probably better than no airway. It's certainly less traumatic than an endotracheal tube, and it has a higher first pass success. Yes, there is an increased risk of aspiration. But which is worse? Do I want a failed airway with blood in the airway, can't intubate, can't ventilate, need to do a crike kind of scenario? Or a whole lot of aspirate in the airway, but stable ventilation? I think I would choose the latter over the former. And I should clarify, by the way, throughout this talk, if you have any questions at all, I want you to put them in the chat. I can see the chat on my screen, or feel free to unmute yourselves and interrupt me. I love interruptions. All right, so that was about supraglottic airways. As it turns out, they're not the devil. Moving on to medical calls or trauma calls. I was taught that every single patient transported by an ALS unit should have an IV by the time they arrive to the hospital. And it's within our skill set, so we should stay and play until we get access. And I was always told that there were some meds that you can't give any way other than intravenously. As it turns out, I don't think that's true. Right? Pre-hospital IO, when I was training as a medic, was not really a thing. I'd heard about them. I'd seen one IO gun, I learned that they existed, but I never actually used one in clinical practice. It's sort of like a unicorn, right? My daughter tells me that they're real. I haven't really seen them myself. And Jeff Segal had said, sick enough for an ambulance, sick enough for an IV, right? That's what I had always been taught as well. And so I'd always learned that the only routes of administration were either IV through the tube, sub-Q, which is uncommon, or IM for epi mostly for anaphylaxis, or inhalational, right? Giving nebs. But as it turns out, in cardiac arrest, there were some early trials that showed that IO was worse than IV. But a New England Journal trial came out literally 2 months ago and showed that IO had a higher success rate and first pass and a second pass as compared with an IV with no change in resuscitation outcomes. So this was the 2018 study. And it said the use of IO drug administration was associated with unfavorable clinical outcomes. But from literally a few weeks ago, no difference between ROSC with IO versus IV for out-of-hospital cardiac arrest. No difference. No difference. Doesn't make it better or worse. That just means that whatever you can get, you can get. So at this point, what would I do now? Right? If you have a patient who's in out-of-hospital cardiac arrest or in extremis, what should we be doing with them? I'd probably try for an IV. But if I can't, I'm going to go straight to IO. I used to have a lot of hesitation when I was moonlighting as a medic during med school and IOs were becoming a little more popular. I didn't want to be seen as, oh, couldn't get an IV. It wasn't easy. This guy sucks. As it turns out, no one should judge you for not even attempting an IV. An IO works just as well or just as poorly, depending on how you see it. And outcomes are just as good. But an IO is faster and easier. So these days, I think out of hospital, an IO makes perfect sense. And I'll just tell you anecdotally that at Johns Hopkins Hospital, we used to not stock IO guns readily. And 5 years ago, or 4 years ago, we moved to have an IO gun in every single code card. So now when patients don't have trustable venous access, while people are doing chest compressions at the head of the bed and the anesthesia team is intubating at the head of the bed, someone's putting in a tibial IO during chest compressions. And it works great. All right. So moving away from vascular access, but not far away from vascular access, we'll talk a little bit about resuscitation. I heard if I had a nickel for every time I have said, let's just flood with some fluids. He's hypotensive. Let's give 2 liters wide open. Don't worry about it. The trauma team will check some labs. He needs volume and not blood. I have said this phrase so many times. So many times. But what's interesting is that in the last 20 years, there's been a huge shift away from definitive surgery in trauma management. It used to be, when I was a medical student, that a trauma exploratory laparotomy, a big open belly, you'd stay in the OR for 5 or 6 or 7 hours. You'd resect all the bowel, you'd do all of the everything. And as it turns out, in the last 20 years or so, there's been a huge shift away from that and towards damage control resuscitation. So at shock trauma, when there's a gunshot wound to the abdomen, go to the OR, make sure that nothing's actively bleeding, make sure that there's no big spillage of stool into the abdomen, often leave the bowel in discontinuity. So they'll cut the segments of the intestines that are spilled, that have holes in them, and then they'll go to the ICU and keep the patient open. And then they'll come back to the OR 2 or 3 or 4 times for repeated looks. And in between, they'll do resuscitation and keep the patient warm in the ICU. And alongside this shift towards damage control, there's an increased awareness that we should actually be allowing our patients to be a little hypotensive. If I target a normal blood pressure in a trauma patient, I'm much more likely to have increased blood loss. And I'm not talking specifically about, there are some scenarios where this is not true, admittedly. But your gunshot wound to the abdomen doesn't need to have a systolic of 120 and doesn't need to have a heart rate of 70 by the time you drop them off in the trauma bay. Less might be more. And when we talk about the triad of death in trauma, we talk about hypothermia, we talk about coagulopathy, and we talk about acidosis. So if you're giving someone cold crystalloid, you're only going to make your patient more hypothermic and more coagulopathic. So you're making this hypothermia worse, and you're making this, the coagulopathy, worse as well. So it might be a good way to do bad things if you actually dislike your patients. One of my friends, Phil Spinella, is a well-known blood researcher in Pittsburgh, and he always talks about how saline is useful for making pasta, and blood is useful for resuscitating patients. And he always talks about how a bad clinician takes pasta water, aka gasoline, and puts it on the fire of hemorrhagic shock. So I'm not telling you never to give fluids, but what I am saying is we should be thinking long and hard before we volume resuscitate and give all of our traumas a ton of volume, because we may not be helping them. And there's probably a good chance that when we do so, we're actually harming some patients. So what do we think now? 30, 40, 50 years ago, the answer was you didn't need to give anything other than packed red blood cells, just red units. But as it turns out, if we give early clotting factors or whole blood, which is blood that's got all of this stuff, the platelets, the factors, in addition to red cells, there's about a 30% decrease in trauma mortality by giving whole blood. We probably could have saved a lot of lives if we'd known this earlier on. So what does that mean for us? There are really, really good trials out there that have shown benefit for whole blood administration in trauma. And there are even some EMS centers, though not routinely, that are using whole blood resuscitation in the field in traumas. They're giving group O blood, whole blood, in traumas for resuscitation instead of giving crystalloid. The challenge here is not medical. The challenge here is reimbursement. Because we know it works, and we know that in trauma patients, early whole blood saves lives. The challenge is, how do we do it in a way that's financially sustainable? Because you have to have that whole blood, which only lasts a couple of days under storage. How do you have that in the bus or in the chopper ready to give to a patient? And what do you do if the blood expires? It's expensive. It's a couple $100 a unit. So the challenge is not whether it's better. The science is clear that it's better. The question is, how can we operationalize this? And if you're a reader of the New Yorker, last month, there was a great article about the quest for artificial blood. Because as we know, all units of red blood cells or FFP or cryo or platelets is taken from human donors. And there aren't enough of them around. And now there's a lot of talk in the blood world about using hemoglobin-based oxygen carriers, basically red goo, that carries oxygen. And that may be the future. It's supposed to be coming 10 years from now for the last 25 years. So I don't know when it's going to come, but it wouldn't surprise me if some of the younger folks in this group practice in a time where we're giving blood substitutes to trauma patients. That would be an amazing, amazing advancement. If you're interested in reading the article, it's free from the New Yorker. It's a fantastic, fantastic piece. So what's the takeaway here in terms of trauma resuscitation? Permissive hypotension saves lives in major trauma. Giving a lot of saline doesn't save lives. So when we think about what we should be doing in trauma care, I was always very offended as a medic that a trauma call was a BLS call, because I thought that I, as an ALS provider, had more value to add. And now there's been a trend towards scoop and run rather than stay and play. And I think that is a fantastic, fantastic paradigm, right? Getting the patient to definitive care is better than stopping to resuscitate with crystalloid. And we should be pushing our regulators and our administrators to be talking about pre-hospital whole blood for trauma. This is a picture of a fire company that's hanging some units of whole blood that they've kept in a cooler in their ambulance. So we should be pushing for our systems to allow for whole blood resuscitation, especially for trauma patients. Right? Trauma patients don't need pasta water, they need blood. And what if you can't get it in fast enough? I just spent the last while talking about permissive hypotension. And we specifically talked about the trauma patient. But what about the patient from the nursing home who's got septic shock from a urinary tract infection? They're 70s over 50s. They're severely hypotensive. They have altered mental status and they're tachypnic. What about anaphylaxis, right? The anaphylactic shock. What about the patient having a STEMI who is in cardiogenic shock, right? What should we be doing for these folks? Flooding them might not be the right idea. So back in 2003 to 2008, when I was working regularly as an EMT and as a paramedic, dopamine was it. Not an option, but the only option for vasopressor to give during trauma. During medical hypotension. The problem is that if you ran pressors that we know are better, norepinephrine or epi, through a peripheral IV, you were worried about infiltration. And the challenge is, yeah, it's a real thing. But if the patient coded, then of course you gave him a milligram of epi, but we couldn't use tiny bits of epi. And some of you may remember the dopamine clock, where we were counting out the drips from a micro dripper set to know how many drips per minute equaled how many mics per minute of dopamine that our patient was on. Crazy to think about that. I hope no one's still doing that today. In the OR and in the ICU, what do we do instead? We have syringes of vasopressors. Right? We have syringes of phenylephrine or ephedrine, but gradually we're transitioning to norepi and epi. And it's really helpful, especially if I take a patient who's medically unstable and I go ahead and intubate them. I know that transitioning from the patient breathing spontaneously to positive pressure ventilation is going to drop preload, is going to drop their blood pressure. And instead of flooding patients with fluids, we should be helping their blood pressure pharmacologically. And I know that Sean Barinholtz used to carry around some phenylephrine syringes when he was riding in ALS units. And I love that idea. I can think back to numerous cases as a medic when it would have been helpful for me to give vasopressors that actually worked instead of dopamine, instead of just giving crystalloids and a weak pressor like dopamine that causes arrhythmias but doesn't actually help the problem. All right, it's at this point that at every point in a talk, you have to see cute pictures of people's kids. So I wanted to show you, this is my son. My son is 5 and he insists that he will be a firefighter. We had his birthday party 2 years ago at the Pikesville Fire Department. So he may be a future recruit for you. This young lady is 7.5. And unless you have unicorns and chariots, she does not want to ride with you. I would love to be any help. If you want to talk about any of this stuff at all, don't be afraid to reach out. And if you are interested in a career in medicine, as anyone who is in medicine will tell you, it is a difficult and challenging career, but it is also deeply, deeply rewarding. If you're interested in a career in medicine, I would be super happy to talk to you. First, I'll try and talk you out of it, but then I'll try and talk you into it. It's at this point that I want to make this open for questions. You can please feel free to unmute yourselves, feel free to put it in the chat, or go to the poll everywhere. I want this to be a dialogue. So tell me what's on your minds. I got a message in the chat that says that in Montgomery County, they've just started giving whole blood and have had great results. I think that's awesome. The challenge is always money. But for trauma, whole blood is king. I love that. I'm so glad that you're starting to do that. All right. What else we got? Is permissible hypotension specific to trauma, or is that something that's potentially beneficial for medical hypotension? So it's only really been studied in trauma. That being said, low blood pressure in a medical situation is not great, but I'm also not sure that I would stay in play for a long time to fix blood pressure when the definitive treatment is antibiotics and source control. And so, yeah, permissive hypotension is really only been well studied in trauma. But I would also say that you have to ask yourself the question of whether it's the right thing to do at the moment. Yeah. Given your talk so far, what changes in EMS protocols would you suggest? So the challenge obviously is that I'm not working in EMS on a regular basis anymore. I wish I were. Unfortunately, my schedule is terrible. And it's a real challenge. I think one of the big changes in EMS protocols that I would suggest is encouraging IO rather than IV, and encouraging that we should really, really, as best as we can, be getting people to definitive care sooner. We should be emphasizing supraglottic airways or bag mask ventilation over endotracheal intubation. A question was scoop and run was the way I was taught. I'd like to see that come back to the forefront. I could not agree more. I love that. I'm going to star that because I just love that. All right. Curious as to why most emergency rooms do not want to continue with end-tidal capnography. I think the thought is that once you've confirmed that the tube is in the trachea, you've confirmed that the tube is in the trachea, and if it moves, you'll know about it. That being said, I am a firm believer that we should be using end-tidal capnography continuously. And we use it in the OR. We use it in the ICU. And we should really be using end-tidal capnography whenever you're moving a patient or whenever anything changes. What about pediatrics and trauma? The data on permissive hypotension is much less clear in pediatrics. And the challenge is also what's a normal blood pressure in pediatrics. And for the longest time, reference ranges weren't published for surgical pediatric patients as to what a normal acceptable blood pressure actually is. If my 5-year-old has a systolic of 70, is that bad? I don't know. Probably not amazing, but also kind of okay. And so we don't really know. All of the data on permissive hypotension is in adults. I don't think that the answer is crystalloid resuscitation for peds. I think we should probably scoop and run and get to definitive care in peds. Um, but that's important to think about. I see a comment about using the King Airway and LMA as a BLS provider in New Mexico in 2004. The question is the LMA better than non-invasive ventilation at all, or than putting in an oral airway and masking?
Hey, Dave,
Yes, sir.
for the LMA and BLS, I'd like to comment on that. I sit
Yes,
on
please.
NFAC, the State EMS Advisory Council, and we're just starting to look at that right now.
I was about to say, I think that an LMA, in my head, is a glorified hands-free oral airway.
I agree.
And so I think that it is a fantastic and relatively foolproof tool as compared with putting in a rigid oral airway and then having to maintain a seal, especially in a patient who has a beard, especially in a patient who has a very recessed jaw, especially in a patient who's morbidly obese. I think that an LMA is a better oral airway. So I think that it's a great idea to put in a supraglottic airway, but I'm also not involved in policy.
It is being discussed at the state level now
Yeah.
on the
Um,
committee that writes the protocols.
Yeah, and so the question is permissive hypotension. How do you factor in transport time? Some areas could see a 30-minute transport that's still faster than aviation. Is it okay to have extended periods of managed low blood pressure? I do it in the OR all the time. I take my trauma patients in the OR, and while we're doing open abdominal surgery, I keep their systolic in the high 70s, low 80s. Because the question is it worse to aggressively resuscitate and make bleeding worse? Right? No one likes to see a systolic blood pressure that's low. No one likes to see a mean arterial pressure that's low. I get it. But the question is, what is worse? You're talking about masked trousers? Yes, I loved masked trousers. Yeah, I don't know that we should necessarily be bringing those back, but it's just an interesting thing for us to think about. And there's a question in Poll Everywhere about, I did IV Tech years ago. Is there any talk of training EMTs to perform IOs? Is this a much more difficult skill? It does sound fast and effective. From a skills acquisition perspective, the question is, what is the benefit to putting in an IO if you're not going to be administering medication through it? And I'm not sure that there is one. And so I don't know. I think expanding the scope of practice of EMTBs to put in supraglottic airways, in my head as an anesthesiologist intensivist, makes perfect sense. I'm not sure that it necessarily does if you're putting in an IO in the field, but you're not necessarily going to give any medications or volume resuscitate through it. I think that's a much more difficult value proposition. Dr. Sega, I don't know if you have any thoughts about that.
Uh, I would agree that because at that point you're delaying transport.
Yeah. Yeah. I think that the question is always, what's the least worst choice? And I'm not sure it makes sense to put in an IO as an EMTB
Not if you're not going to use it.
if you're not going to use it. That's right. It's a fast enough thing that I'm not sure it makes a whole lot of difference. IO takes 10 seconds. All right, what else we got?
Plus setup time.
Plus the setup time, that's right. You still using hair traction splints? Anyone using hair traction splints?
We do.
That thing was so cool. The ratchet, oh, so cool. Things I miss about EMS. All right, what else we got? Any other thoughts? Any other musings? Are we using kids? Extrication devices?
Yes.
Haven't thought about that in a long time. So I was telling Dr. Sagel, he and I shared this experience. I learned to intubate on my belly on a kitchen floor, right? That's when paramedics intubate, is people usually pass out, as you all know, either on the toilet or in the kitchen. And so I learned to intubate on my belly on the tile floor. And when I first started anesthesia residency, I was always intubating, leaning forward, looking down. And I think that's been one of the biggest adjustments that I've had, is now I stand up. I don't think I intubated a single person standing up when I was a medic, which is so different. Intranasal Narcan was not a thing when I was a medic. Now it's a BLS thing. It's amazing what's changed.
So I'll just say that I've really enjoyed tonight's lecture, although I'm feeling a little old listening to some of the stuff, but thank you very much. I'm
Thank
Kathy.
you.
I'm from Pikesville.
Rockin'. Thank you. There's a question in the Zoom chat about preferred location for IO. Anybody know the 3 locations you can put in an IO? Someone shout them out.
Ankle, knee, and arm.
Okay, so leg we said, arm, where's the third?
Ankle.
Ankle.
It's actually, the AHA actually doesn't say that you should put it in an ankle.
Just the shoulder.
They say humeral head, so in the shoulder. They say tibia. And the third option is actually the sternum.
Yeah.
But the challenge is that their IO needles come in 3 different depths. You don't want to use the deep depth in the sternum. You don't want to use the deep depth in the sternum. It will work. You'll be in the heart.
The wrong way.
But you shouldn't do that. So I think it makes sense. It's certainly easiest in a cardiac arrest scenario to put it in the tibia, right below the knee, really flat bone, really easy. The challenge is in a trauma, if you have an abdominal hemorrhage, you don't want to put access below the diaphragm. So in a trauma, we generally put our IOs in the humerus. In medical arrests, we generally put our IOs in the tibia.
I'll bring up one thing for the sternum. Don't do it if you think the person's going to code, because it will be in your way. 2, I've had a couple cases now as a cardiac anesthesiologist where older people, it has gone through, and there's very important structures on the other side. So you have to have the right size needle, and you'd like a strong sternum, especially not someone who's osteoporotic.
I have never seen a sternal IO go well, is what I'll say.
I've seen it on young soldiers, but not on really anyone else.
More of a general question, feel free to skip it too far. Do you think there is a definitive limit to the ultimate scope of practice for BLS providers? That is a complicated and controversial question. I think that when I first trained as a medic, my instructors were some of the original New York City medics who were the docs of the street. And so it was much more of a sort of military medic style training, sort of a PA style training. Whereas now I think maybe it's grown into an EMT plus plus. So I think that the training model is a little different. I think there's a limit to the scope of practice for BLS providers, right? I think medication administration beyond a couple of medications should probably be for someone who has a little bit more sort of training in pharmacology and physiology. But that's a complicated and also political question.
Another thing looked at in that regard is if you break the skin, such as an injection, although now like EpiPens have crossed that. So it's interesting.
Yeah, I was frustrated when I was an EMT that I couldn't do more stuff. But the problem was that I didn't know what I didn't know. And the challenge is that you don't know what you don't know until you know it. And so I think there are some things that are a relatively easy sell. Putting in a supraglottic airway as an EMTB, I personally think makes perfect sense. Giving IV push dose medications as an EMTB, I think is way beyond the training. Just my 2 cents. What is the airway that scares you the most? The one that 10 people have tried before. I think that's a fair bet. There are certain predictors of difficult airway from a patient perspective. So if the patient's had head and neck radiation, they have a base of tongue tumor, those things really scare me. Angioedema airways really scare me. Patients who've had prior tracheostomies sometimes scare me because they can get narrowing or stenosis where they had their tracheostomy before. But I'd say probably angioedema and head and neck radiation. Jeff, I don't know what you think. Morbidly obese airways can be challenging. I agree with you, though I think that's probably less true in the era of video laryngoscopy. I used to joke when I still joke with our residents that if you got to be a BMI of 60, your mouth opening is big enough for a cheeseburger. So it's probably big enough for an endotracheal tube. But yes, I think it can be challenging, especially without the right equipment.
The airway I'm most afraid of is epiglottitis.
Yeah.
Now with the Haemophilus influenza vaccines, the Hib shots, we don't see them anymore. But as a resident and junior staff before the vaccine, many a trach from failed intubations, and the distinct baritone sound of the pulse ox and the heart rate going down.
It's terrible. I couldn't agree more. Yeah. And the question is, have you ever intubated a child or baby? More times than I care to count. They're different. Tiny airways are different. You should really respect the tiny airways, but we have LMAs that go down to a size 00 that fit a tiny neonate. I put an LMA 2 weeks ago in a 27-week preterm kid. So yeah, you don't always have to intubate them either, but it's terrifying. All right, Dr. Segal, have I scared the pants off of your team? Have I bored the pants off of your team already?
I think so. Actually, I think everything was very appropriate. It's interesting because I got my EMT, as I was telling you earlier, back in like 1981. And when I took it, it was a 110-hour course. And now the time has doubled. And there's certain things we don't do anymore that we used to. And there's a lot more things that people do now that were not part of it. So I think the future is always bright and always should be looked forward to. It will evolve, and I've never seen it evolve for the worse. I think it will only evolve for the better. A lot of it is now becoming more science-based, thank goodness, and we'll see. I mean, I'm looking for the stuff, at least like in ALS now, where they're going to avoid taking patients to the hospital because they're going to be making more decisions. Should we take them to an urgent care center versus an ER, or should we put them online with a physician through telemedicine at home, as opposed to clogging up our ERs, and maybe they just need a prescription called in for that sore throat and give them the amoxicillin. I mean, many a time I've been on an ambulance call where I wish I could just give them a script for amoxicillin and you'll be fine. Follow up with your doctor in 2 days, but I don't. And more than half, I won't tell them I'm a physician, but I'm like, they're going to hate me in the ER for this. But we can fast track those now into the waiting room. But
yeah, one other thing that I didn't mention is that ACLS is not simple, but I have found it to be in some ways too simple, in the sense that we give a milligram of epi to an NFL player, but we also give a milligram of epi to your 45-kilo nursing home bedbound patient,
Yes.
cardiac arrest.
When I give a talk, I said when I was an internist, and I used to compare the ballerina versus the NFL quarterback with the strep throat versus the anesthesia. In internal medicine, they both get amoxicillin 500 milligrams 3 times a day. In the operating room, it's body weight. Everyone is made the same by body weight, whereas you can't tell me the 100-pound ballerina versus the 285-pound football player are the same dose, because they're not.
Yeah, and I think that's where a lot of the science is going to have to change. And Sean Barinholtz was a big proponent and a pioneer of decision science, and specifically in implementation science, and thinking about how we take the data that we've learned and actually apply it. And so maybe we should be thinking about taking ACLS, and it's maybe gotten a little too simple in some ways, and we should be individualizing it a little more. I think that's one area that will likely change over time.
Well, that's actually started a little bit. They now have ACLS for the operating room,
Yeah,
and you have
pearls.
ACLS,
Yeah.
right, and then for the OB patient. So they're just starting to branch it out. And then you have the ACLS advanced provider, which
Right.
hopefully the hospital hasn't found out about that yet, because then that'll be another credential we'll have to pay for. But that is just starting now, but I think for the wrong reason. I think it's more for the AHA to make money. Yep,
That's all it is. Well, thank you very much for having me. I really appreciate it, everybody.
for coming. I will bring you back. I know all where you hang out.
All right. Thanks again.
Um,
Ray.
Please, if you're interested in getting your MIMS CME in the chat there's a link. Use the second link that was posted. Just reposted, and you can get your continuing ed this way. But no, I thank you very much for being here. Like I said, I will trick you into coming next year. You watch.
Sounds great. Thank you, sir.
All right. Thank you for having us. Thank you, everybody, for coming. Anybody have any other general questions on anything? Say so now or forever hold.
Great class. And it's interesting how in the 70s, what we did as a CRT is starting to come back around.
I've noticed that. You're right. What's old is new
All
again.
that's old is new again.
It's old
right?
as new.
I was saying something to that last week to somebody about that for something. You were correct.
All we got to do is bring back the mullet and the station wagon. We're almost there.
Ford tried to do that with the Edge or whatever it was, and it wasn't well taken. The car that was looked a little bit like a station wagon and a little bit like an SUV. So times change.
The Flex.
The Flex. Yeah, the Flex. Couldn't think of the name. Thank you. Take care. Great class. Thank you.
Thanks.
Thank you for coming.